Good afternoon, John Snyder here for another edition of Newton-Wellesley Medical Group Lunch and Learn. Our last edition of 2021. We are going to take the next 2 weeks off due to holidays that are coming up. So just so folks know that this is the last edition. We are very happy to welcome Dr. Ethan Healy here to talk to us about hip pain in the athlete or the pseudo-athlete. Next slide, please, Ethan. So busy slide, but just to kind of give you guys a tickle of all the different talks we've had over the year. I believe this is a majority of them, or maybe all of them. And this also gives me a chance to thank a few people. First, Audrey Bossi, who helps keep this schedule in line, and Jane Hayward, who helps keeps the slides going. So thank you both. We cannot do this without you. Of course, Holly, who is the co-host with the most. Thanks, Holly, for doing all of this for us. And then I also want to shout out to Jacqueline Kalelis, who helps me get this on the web, on YouTube, and on our intranet. And that leads me to this discussion over the next 2 weeks. Feel free to log on to either Newton-Wellesley Medical Group intranet to hear any of these great talks. Or also, if you don't want to log on there, you can go to YouTube and search Newton-Wellesley Medical Group Lunch and Learn. And these talks will be there. Plenty of great talks we've heard over the years: seizures and spells, viral hepatitis 1 and 2, to name a few, chronic sinus disease, elbow pain, back pain, and the list goes on. So please take advantage of the next couple of weeks, and please feel free to go check those out. Next slide. And that's what I just said. Next slide. Given the surge here at the hospital, as well as also our feeling of trying to keep people out of the emergency department as best they can, we wanted to remind folks about our family medicine and walk-in center in Waltham. It is open Monday through Friday, 10 a.m. to 6 p.m. No appointment is necessary. Traditional walk-in services are taken care of there by our staff. Records will end up in Epic because they are our staff, and it is a office copay. So feel free to use that for your patients. Next slide. X-ray and blood draw right on service. This is a nice service. I want to make sure folks remember, and I do tease this a lot, but physician care concierge service has been extended for a full another year. This is a free service for you, just logging on community.circles.com. And they will find you people to do things for you and also rate them, such as appliance repair or shoveling snow. Supposed to get some snow this weekend, or fixing the gutters on your house or your roof, or other things like that. They vet these folks, give you a little background on them, and even sometimes we'll make appointments for you. So this is a free service. Please take advantage of it. We are covering the cost for all our providers, physicians, and APPs. Next slide. And take it away, Dr. Healy.
Thank you, John. That was great. Nice intro. Appreciate that. Appreciate the time to give a quick talk about hip pain. First of all, who am I? I'm Ethan Healy. I'm a member of the Orthopedics New England orthopedic group. Team physician for Framingham State Athletics, so I cover their mostly hockey and football games, but do see a fair number of student athletes from that school. Team physician for Lincoln Sudbury High School as well, which I just started this past year. My specialization, I'm fellowship trained in sports and arthroscopy, mostly hip, knee, and shoulder arthroscopy. And general sports medicine, so Achilles injuries, quadriceps, patellar tendon, any type of sporty type injuries. I also do some arthroplasty procedures of the hip and knee, and some lower extremity trauma as well. Who are we? We're Orthopedics New England, or 18-member group. Dr. Rocket earlier in the year gave a talk, a lunch and learn as well. So we already gave you the intro. Our backline, if you ever have any questions, concerns, patients that you need seen, just call the backline. It's the easiest thing to do. It'll directly go to someone, either a secretary or a manager, and we can accommodate whatever you need. Denise is sort of our point person. It's dspring@partners.org. And if you don't have anything urgent, you can just email her and she can facilitate anything logistically. Our group is 18 members now, so it's grown. I think it's been around since the 70s, since original member, I think, was Carl Spector. We have 8 orthosurgeons. We recently had a Dr. Ramsden, who's a joint replacement arthroplasty surgeon who does primary total joints and revisions and more complex procedures. So he just joined us this past fall, about 3-4 months ago. We have a strong sports and arthroscopy group. There's 4 or 5 of us that do a good portion of that. We have a spine surgeon, hand and upper extremity surgeon, and then a foot and ankle as well. We have 2 PM&R docs, Dr. Fino and Dr. Sullivan, that do a lot of our injections, both spine injections and joint injections, which is great to have them on board. We have 3 podiatrists for any foot and ankle needs, and 5 PAs that just basically make the place run more efficiently. They can see a lot of acute or subacute consults, patients that need to get in and be seen. So it does make us more efficient here. We have 3 offices. We have the Newton-Wellesley Blue Building office. We have a little bit bigger space in Natick, just across from the mall. And then our newer office is in Hopkinton, and that's a little bit more of a satellite office, smaller, but does help with patients that are coming from Westboro, Hopkinton, that area. So what's my talk about? Hip pain in the athlete or pseudo-athlete, because as everyone's aware, many patients think that they're better athletes than they actually are. I have to acknowledge, I don't have any disclosures regarding this talk. Dr. Coker and Dr. Yang, when I was a fellow, taught me a lot about hips, hip pathology, hip arthroscopy, so I have to give them kudos. I also used a couple of their images from their arthroscopy setup. The causes, so this is a very broad topic, but I'm trying to pare it down just to sort of athletic or I guess sports type injuries or disorders. You can think about it in 2 major categories: extra-articular and intra-articular. Extra-articular, probably the most common thing I see is this Peritrochanteric Pain syndrome, which used to be labeled as just trochanteric bursitis. It was, we're kind of moving away from that label because it's probably it's almost for sure more complicated than that. Trochanteric bursitis does happen. That's just, inflammation of the bursa that can progress to sometimes tear of the abductor tendon, which is typically the gluteus medius. And then some younger folks will have a external snapping hip. There's also an internal snapping hip, which I'll talk about, strains, the ever popular Piriformis Syndrome. So I'll try to explain that a little bit. And then hernias, which are in quotes because it's not actually a hernia. And then another broad category is just intra-articular problems. So labral tears, which is all the rage over the last probably 10 to 15 years. That diagnosis has been has really skyrocketed because we can actually diagnose it and treat it now. Stress injuries, such as stress fractures, cartilage injuries, or degeneration and loose bodies. I'm not going to really delve into arthritic conditions or degeneration during this talk. That's really a separate talk in and of itself. The other thing I didn't list on this talk is back pain. So back pain or radicular pain can disguise itself as hip pain or thigh pain all the time. Happens very, very frequently, and sometimes that is a tricky diagnosis. Typically, I'll say that posterior hip pain, butt pain, gluteal pain, that is very commonly referred from the back. So facet arthritis or degenerative disc disease can very frequently be referred to the gluteal region or posterior hip. Patients may not have any real back pain, and they'll localize it to the posterior hip. I'll spend a bit of time on Peritrochanteric Pain syndrome. That's sort of what we're trying to label it at this point, rather than just calling it trochanteric bursitis. So there is a bursa between the IT band or the tensor fascia and the greater trochanter at the hip. So you get this friction of the IT band with repetitive use, and that can irritate this soft tissue, especially the bursa, and cause pain. It's usually does not radiate. It's right at the tip of the greater trochanter, patients can localize this very, very well. They'll say, oh yeah, I have pain right on the side of my hip. Can happen with typically repetitive motion type things. So hiking, cycling, running, and some sports like ballet where you're standing on one leg for a portion of it. Again, can sometimes radiate down the side of the leg, kind of follow the track of the IT band, but that's not real common. Usually it's worse with activity. A lot of patients will complain that they can't lay on that side, so they'll have nocturnal symptoms. It'll frequently wake them up. And that, frankly, is the number one thing that brings people in general. Because if you can't sleep, you got to do something about it. Occasionally this will be traumatic. So you'll get a history of, patient will be playing football or hockey and get hit in the boards or tackled into the turf. And then they'll have, a traumatic hemorrhagic bursa. Relatively rare, but does happen. You can also get a deep trochanteric bursitis, which is just a little bit deeper layer. It's deep to the tendon, the gluteus medius tendon, but similar, very, very similar symptoms. It's a little bit, more focal, I guess, but same treatment. Diagnosis for this, really, you can get almost all of it from the history. If somebody says, oh yeah, I have pain right on the side of my hip, and they take one finger and point to the spot, almost always that's this peritrochanteric pain or trochanteric bursitis. On exam, it's tender there, and Ober's test is an easy test to perform. Just have the patient lay on their side. What you're testing for is actually tightness of the IT band. You're not actually trying to elicit pain, but you basically bend their knee up about 90 degrees and see if the knee falls down toward the table. If the medial side of the knee hits the table, then that's a negative test. But in most cases, it's tight and it'll sort of bounce above the level of the table. Treatment for this is almost always non-operative. So physical therapy, IT band stretches, gluteal strengthening are very helpful, and most of the time that will resolve the problem. Rest, ice, and SEDS. Occasionally with folks that, if it's been going on for several months, I'll commonly do a cortisone shot right in the office. I don't love to repeat these over and over again because that can signify some underlying problem, structural problem. But, one or two cortisone shots here and there is probably not a big deal. Some patients have started to ask me about PRP, platelet injections. I've done a handful of those. In the selected patients that I've done, they have been helpful, but I don't think it's a panacea. Very rarely will this require any sort of soft tissue release. I've done one in my career. It's been 11 years, so it's pretty rare. External snapping hip is similar but different. This typically occurs in a younger patient population. Patients will come in and say, my hip pops out. Their hip is not obviously popping out, but they'll feel kind of a snap or a pop on the side of their hip. Most patients, it's very common, much more common in females. Most patients will actually be able to reproduce it or elicit it if you ask them. Typically, I'll just have them stand up and ask them to do the hip popping thing. And most of the time, they'll just sort of shift their pelvis back and forth, shift their weight back and forth, and you'll either be able to hear or feel this snapping on the greater troch on the outside of their hip. In most cases, kids, so I say kids, it's usually adolescents, sort of preteen to late teen age. They'll come in and say, my hip pops. Oftentimes they don't have any pain, but they want to get it checked out because it's just so shocking that it's making, their hip is making noise. Over-test is usually positive, maybe some tenderness with palpation, but this is almost always treated with stretching exercises, reassurance, and conservative measures. We start to get into some real pathology now. If this progresses and you get it sort of a chronic pain on the side of the hip, that can cause some damage to the underlying tendon. So the abductor tendons can become damaged. We think of it as sort of the rotator cuff of the hip. It's the gluteus medius where it attaches kind of is a watershed area. So there's not great blood supply there. If you get this chronic sort of low-grade inflammation, repetitive trauma, irritation, and abrasion, you can eventually start to wear down the tendon. Very commonly starts as a partial tear and can sometimes continue to a complete tear. Risk factors typically is middle-aged, late middle-age patients. Females are much more likely, at least 2.5 times more common. There is an association with low back pain and knee arthritis for whatever reason. But this is more of an attritional tear, very, very rare to have an acute traumatic rupture or traumatic tear. The typical story is, patients will have, 6 months, a year of lateral hip pain that doesn't go away and is slowly getting worse. Treatment, most of these can be treated conservatively without surgery. Incomplete tear where the tendon is actually attached, you get a little partial tear to the tendon, but the function is still there. If you can get the pain to come down and it's not painful, patients usually are happy and treatment is successful. Basically the same modalities that I talked about before. If all else fails, you can repair these surgically. A complete tear is a little bit different story. A lot of times you'll get pain and weakness. If people just have pain and normal function, you can sort of treat them like an incomplete tear. If they have dysfunction, so patients will say, I'm having pain, I've had pain for a long time, but now suddenly I'm limping, I have to use a cane, a walker, or something to help get around. That signifies some dysfunction and some weakness to the abductors. They'll typically have this Trendelenburg gait or lurch because they can't hold their pelvis level. The abductors are not firing properly because they have a tear, it's torn off the bone. This is a little picture of the most recent repair that I did. I do them open, you can do them arthroscopic. I think it just adds time to the case. And you basically just reattach it to the bone. Internal snapping hip is a slightly different phenomenon, but similar to an external snapping hip. It's usually the psoas tendon that people will feel. And that'll be an anterior hip pain. That'll usually happen with sort of a rotational type maneuver. People will plant their foot and turn. Very common in dancing, dance, ballet, martial arts, and stuff like that. In general, tends to be female patients, and it can be painful if it happens frequently. But most of the time, again, this is a situation where a kid will come in and say, "My hip snaps. Why is it snapping?" But they don't necessarily have any pain from it. The phenomenon is occurring because the psoas tendon is snapping over the front of the femoral head with rotation, because it does drape across the front of the hip. By and large, this is conservative care, physical therapy, stretching, NSAIDs, and activity modification, typically works. For dancers, high-level ballet dancers, it's hard to modify their activity. And a lot of times we just get it to settle down with injections and PT. Very, very occasionally we'll do an arthroscopic release for this. I think, again, this is maybe 1 or 2 of these in my practice ever that I've had to release. So very unlikely. Strains, these are very, very common injuries. Muscular strains, the classic orthopedic grading system, 1, 2, and 3. That's like mild, moderate, and very bad. So your grade 1 is minor disruption of the muscle fibers. Grade 2 is very common. That's sort of a partial disruption. And grade 3 is very, very rare. That's a complete disruption of the muscular unit. 2 joint muscles like the hamstrings, where it spans both the knee and the hip, are more common. Typically happens with an eccentric contraction during acceleration or deceleration. Flexor strains, most people will feel sort of a pull or a snap at the time of the injury. It'll happen anteriorly in the front of the hip. Usually sprinters are people who are kicking, trying to plant and kick a soccer ball, for example. That's what they'll feel. The key to the exam there is there's no pain really with lateral movement. So you can have patients go side to side and they're fine. But if they go front to back, then that elicits the pain. Hamstring strains, very common. By and large, most of these can be treated without surgery as well, except for a full thickness avulsion at the insertion of the pelvis. You can usually tell, patients will come in a few days after this injury. There will be a massive amount of swelling, ecchymosis, even tracking down into the back of the leg and calf. Almost everybody says, oh yeah, I felt a pop or a snap. And these sometimes need repairs if they're completely torn off of the pelvic bone. Oops. Other strains, so a classic sort of groin pull, it's the old terminology, but it's an adductor strain. So patients will give a history of having their hip get forced into abduction or externally rotated. A lot of times hockey players will describe this, skiers, water skiers, lacrosse players. It's basically any sort of external rotation with abduction. That usually is painful with lateral movement, cutting, and that's usually medial-sided thigh pain and sometimes groin pain. These strains almost always are treated without surgery. I don't know what the impulse is, but a lot of people will start stretching these immediately. Just they need to rest basically. So the muscle is trying to heal, and patients will just want to keep stretching them. And I think that's actually counterproductive. You need to sort of immobilize it, let it rest, let it start to heal, and then start physical therapy a couple weeks later. Piriformis syndrome. This is, I personally have not ever seen a true piriformis syndrome in practice. It's basically an irritation of the sciatic nerve in the posterior aspect of the pelvis. The sciatic nerve usually lives sort of deep to the piriformis tendon and muscle. And if that flexes, it pinches the nerve and you get pain in a typical sciatic nerve type distribution. Very common to get a patient who comes in and says they had some sort of traumatic event, they fell on their butt and they've had this pain since. You can get some pain in the sort of sciatic notch area, piriformis area, and it can typically radiate. So a true piriformis does radiate down the leg, similar to a herniated disc having sciatic nerve symptoms. You can, so it's hard to diagnose these. EMG can be very helpful in this instance, where you get people that have radiating pain down the leg. EMG can really localize where that signal disruption is. CT, MRI sometimes can help as well. Diagnosis, basically, if you see some weak abduction, basically the patient can't externally rotate. And sometimes they have pain with forced internal rotation. So if you roll their foot in, that'll kind of elicit that response. It'll reproduce their symptoms. Botox injections, so that's the one thing. Cortisone or Botox injections actually can help with this. Very rarely will need to be surgically released, but there's a few good studies on Botox injections for piriformis, because you inject the muscle, it relaxes, and it's not able to contract anymore, and it does help. Sports hernias, these are actually not hernias at all. Basically, it's a tear of the rectus abdominis off of the top of the pelvis. So hockey players, very common in hockey players, lacrosse, soccer sometimes. People will feel pain with starting a sit-up maneuver. So that's the one physical exam thing is if you have the patient laying down, you have them start to do a sit-up and they have pain there in the groin, kind of lower abdomen. That can be a sports hernia. Hard to diagnose these. Sometimes the MRI is not very clear. It's only about 70% sensitive to rectus tears. Ultrasound has some role there. Many of these end up being repaired. To be honest, in higher level athletes, almost every one of them needs to be repaired because they won't respond to the usual core strengthening and PT. Stress fractures, so we're kind of getting into intra-articular stuff. Stress fractures, basically if a kid comes in, young kid, or a younger athlete comes in with groin pain or hip pain, X-ray looks normal, you got to think stress fracture, especially if it's a runner or somebody who's on their feet a lot. The workup for that is obviously X-rays at first, but that very commonly is negative because the x-rays lag behind about 3 or 4 weeks. Usually a bone scan or MRI to diagnose. These days, almost everybody gets an MRI because it's easier to get an MRI than a bone scan, in fact. Treatment for that is just rest, in most cases, protected weight bearing, and has very good prognosis. The one exception to that is that if people have a tension-sided lesion, so that the actual stress fractures on the top of the bone or the superior part of the femoral neck, a lot of times we'll pin those so that it doesn't actually displace, because that can be a devastating complication of these injuries. Labral tears and hip impingement. I'm going to just breeze through the last couple of slides here, but this is a decent part of my practice. I do hip arthroscopy, several of these every month. Labral tears, this is a very common finding on MRI, but not everybody needs to have labral tears repaired. Younger patients, athletes typically do. People without arthritis typically will have continued pain. Older folks, older meaning over 40, a lot of times won't have necessarily any pain from a labral tear. So even if you see one on MRI, it can a lot of times be treated without surgery. The labrum is this sort of gasket that goes around the socket, gives a little depth, provides a suction seal, and helps cushion the articular surface in the hip. How do you get a labral tear? Where 90% of the time you have some sort of bony problem. So you basically have these 3 configurations of the hip joint. Either has too much bone on the femur, which is called a cam lesion, too much bone on the socket, which is called a pincer, or mixed. Frankly, mixed is the most common type. This can cause impingement, basically. So the femoral neck hits the front of the socket, causes repetitive trauma to the labrum, and it can tear. So this little picture is an arthroscopic photograph of a pretty big tear and a flap of cartilage, which is the worst thing to see. Pincer impingement is very similar, but that's more socket-sided. You typically see a sort of a rim on the femoral neck where it's been hitting. There's been bony impingement for months or years. Physical exam, probably the most important thing is this sort of internal rotation and flexion maneuver. That will almost always elicit anterior hip or groin pain. Very, very reliable physical exam finding. So if you have somebody that comes in and says, I have pain in the front of my hip or my groin, you do this little maneuver, and if it's positive, you got to think labral tear. Also, if people do a C sign, so they'll say, they'll take their hand like this and say, my hip hurts right here, and put it around the side of their hip. That's very indicative of a intra-articular pathology or a labral tear. Workup, X-ray, MRI, the usual stuff. This used to be treated with open surgery, which was a very big dissection, really morbid procedure, high complication rate. Now we can do it through the scope, which is what you see here. It's a complicated setup. Not everybody does this procedure, but it is a very successful surgery generally. People tend to do well, and basically there's 3 things that we're doing. We're trying to trim down the socket, trim down the bump on the femur, and reattach the labrum, which is what you see up in the upper right-hand side. The main thing I think is that it restores this suction seal and takes some pressure off the remaining cartilage in the hip. There's my rehab. One little pearl here is that people over 40 tend to do not as well as younger folks. And that's probably a relationship to degenerative changes that can happen later, after 40. If you start to get arthritis, then the outcomes for hip arthroscopy are not as good. Loose bodies, these are always fun cases, but relatively rare. You can get people that will have problems with the synovium that'll produce these loose bodies like osteochondritis, synovial chondromatosis, things like that. That's pretty much it.
Thanks, Ethan. You guys, if you have any questions, you can throw them in the chat box. I know we're coming up on the hour. One question I had, with the labral tears, when you see these folks right away and they're in pain, does it make sense to sit on them a little bit because the pain would go away, like the non-athletic 40, 45-year-old folks? Or do you tend to, it's one of those findings I always, if you get an MRI, you always see it there when people have the hip pain. I always wonder if we just kind of cool them down, things would get better. What is your practice been?
Yeah, that's an excellent question. In general, people that I see have actually had these symptoms for a long time already, 6 months to a year in most cases. Like you mentioned, I mean, you'll see it on the MRI, but it is hard to interpret what that actually means. But if they're having groin pain and it's been there for 3 or 4 months, it's okay to try, physical therapy, activity modification, and sometimes they will settle down. Not every one of those needs to be repaired, like I mentioned, but if it's been persistent, certainly anything over 6 months, I would tend to treat that.
Thanks. All right, well, 1 o'clock. Hope everyone has a happy holiday season. Once again, we're not going to be here for the next 2 weeks. Good time to catch up on some old talks that we have archived up on the medical group YouTube channel, as well as also on our intranet. Dr. Healy, thank you so much for coming. You can catch Dr. Healy at one of his 3 offices. And he is one of the fewer orthopedists who do hip arthroscopy. So thanks for coming. And I hope everyone has a happy and a healthy new year. Bye.